Hi everyone, today we'll be covering a couple of renal-related approaches. I'll be talking about acute kidney injury, haematuria, and urinary frequency. So for acute kidney injury, this may be tested in the station 5 or station 2 case, where it could be a referral from a GP, where a patient is actually found to have a rise in creatinine or just a high creatinine to begin with. And of course, at the outset, it is important for one to differentiate whether this is a true acute kidney injury or whether it's chronic kidney disease with progression or whether it's an element of both. But just to focus on acute kidney injury, I'll just be going through the causes as well as some of the basic evaluation. So I think most of us are familiar with the framework of pre-renal, renal, and post-renal approach. So for pre-renal, commonly it will be patients who have ongoing hypoperfusing states. So this can be due to hypotension, sepsis, diuretics even, and in cardiorenal or hepatorenal syndrome too. In terms of large vessel disease, renal artery stenosis can, especially if it's bilateral, can cause acute kidney problems as well, on top of having a precipitant such as initiation of ACE inhibitor ARB. And in terms of the renal causes wise, I think of it in terms of glomerular, microvasculature, as well as tubulointerstitial. So for glomerular, typically if there's an AKI, this is more in keeping with a nephritic picture, and we'll go through the causes of glomerular pathologies later on. I think the vascular group, or rather the microvasculature group, is an important group to consider because this is something that sometimes we miss out in terms of our approach and in terms of the consideration of our differentials. So I think there are a few important conditions. So it could be a primary vasculitic mediated approach. So, or rather process, so conditions such as wedgeness, shock straws, anti-GBM, for example, and even scleroderma renal crisis also is mediated through a endothelial dysfunction and damage pathophysiology. I think the second group in terms of microvasculature would be the microthrombi and clots that can happen in conditions like hemolytic uremic syndrome, as well as thromboembolic states such as infective endocarditis. Hence, it is important to take a history and evaluate the patient for any clinical features that may predispose to such phenomena. So the third group is the tubulointerstitial group, of which ATN, AIN, ATN much more common than AIN, and common culprits would be that of medications, sepsis, and some of the connective tissue disorders, apart from mediating damage through the glomerular process, can also affect the tubules as well as the interstitium too. So conditions such as SLE, Sjogren's, and some processes may not necessarily be a straight clear-cut ATN or AIN, but important to consider also would be urate nephropathy that can happen in gout or tumor lysis, where there's a surge in the uric acid levels. Other drugs like acyclovir, chemo, and rhabdomyolysis as well. So in terms of AIN, so this is number one, much less common than ATN. It can present with associated fevers, rash, and eosinophilia, although the triad may or may not be present. So next would be the post-renal or post-obstructive group. This typically occurs when there is bilateral obstruction or there's unilateral obstruction in a single functioning kidney, and pathologies to think about would be stones, malignancy, BPH infection, or just urinary retention that can be multifactorial, so such as an element of BPH with constipation or certain opioid or anticholinergic medication that may have predisposed to retention. Okay, so another way to think about it, instead of a pre-renal, renal, and post-renal approach, would be in terms of a diagnostic sieve. So if you think about it in terms of infective, inflammatory, neoplastic, endocrinopathies, and metabolic, etc. So I think this could be another way And as you can see here, this list of conditions is not the most tightly curated, as it includes some of the chronic kidney disease conditions as well. But this is just another way to think about the different causes, and sometimes in terms of depending on how you approach your history taking, especially if this is a long case, more of a, then one may want to have a thorough systematic review, and thinking about it in terms of an etiological sieve may be helpful in terms of ensuring that you don't miss out on some of these important conditions. So in assessing someone with acute kidney injury, it's important to assess for complications. So mainly in terms of fluid status, solute status, the acid-base status, and the potassium mainly, as well as complications of uremia. And investigations-wise, apart from baseline urea electrolyte and creatinine, full blood count, looking for some of the associations, liver function tests, and creatine kinase is important. But I think in terms of the urinary tests, it is very important that this is sent off from the outset. So urine phase contrast, urine form element microscopy examination to look for the presence of haematuria, as well as urine PCR to look for, or 24-hour urine protein to look for proteinuria as well. Then imaging can be considered for the structural causes, and subsequent investigations is tailored based on the underlying suspicion of what the pathophysiologic process is. And finally, we know biopsy, the gold standard in terms of ascertaining the etiology. So next we talk about hematuria. So I think hematuria, I think about it in terms of a few layers. So the first is to exclude mimic, so beetroot medication such as rifampicin, pigment like myoglobinuria, and obstructive jaundice. The tea-colored urine can sometimes be perceived as hematuria, and ongoing menstruation too. So then I also think about systemic coagulopathy that can be classified into connective tissue problems, platelet dysfunction, or thrombocytopenia, as well as coagulopathy that can be due to iatrogenic causes such as anticoagulation or acquired or inherited coagulation dysfunction. Then next would be to exclude urological causes. So this can be any pathologic process that's taking place in the pelvic calyceal areas, bladder, urethra, and the prostate too. So malignancy, stones, infections, other causes like hemorrhagic cystitis with certain medication like cyclophosphamide and adult polycystic kidney disease can also cause bleeding. And finally, after a urological cause is excluded, then to think about glomerular sources of bleeding, which we'll talk about in the glomerular section of this presentation. So we next talk about the GNs. The GNs, by and large, we think about it whether it's more of a nephritic picture or nephrotic picture. The nephritic picture is the one that is characterized by a frank acute kidney injury where there's a rise in the creatinine that can be associated hematuria, red blood cell casts that we see on the what we call an active sediment that can be associated, hypertension as well. So important causes to evaluate for would be number one, autoimmune conditions like lupus. The pulmonary renal syndrome groups of conditions are very important. So good PACES, wetness. So it's important to take a history for associated respiratory symptoms and hemoptysis. Infective causes such as Hep B, Hep C, HIV, IgA nephropathy. Strictly speaking, isn't an infective cause per se, but can be associated with what we call a synpharyngitic picture, where there's ongoing sore throats and an onset of what sounds like a nephrotic picture. In terms of the nephrotic syndrome group of conditions, so this tends to present with proteinuria, hypoalbuminemia. So the proteinuria range tends to be more than 3 grams per day. There can be a lowish blood pressure, hyperlipidemia, and associated clotting tendencies, especially the nephrotic syndrome is chronic and severe. So number one, it's important to exclude diabetes mellitus, which would probably be the commonest cause of nephrotic range proteinuria. Then the infective groups, Hep B, Hep C, HIV, lupus once again can also present as such. And I think it's worthwhile pointing out the malignancy group. So it can be due to myeloma, which will be an important condition to screen for, as well as membranous nephropathy that can be associated with certain malignancies. So there might be a role for certain serologies like the anti-PLA2R and anti-thrombospondin that can help to characterize the membranous properties a bit better. So lastly, I'll be talking about urinary frequency. So I think this can be a slightly tricky approach because it could be just frequency or it could be an approach to polyuria. But in terms of the stem that's given, it could be something as vague as the patient has noticed that he or she is going to the toilet more frequently. And hence, in terms of the history taking, it is important to attempt to differentiate whether or not this is just lower urinary tract symptoms such as frequency or whether it's true polyuria. So in terms of the frequency bit, I think there are a few things to look at. I think of it as three big causes. So the first is whether it's a primary urological problem, whether it's neurological or whether it's drug related, which kind of sits under the subset of neurological if we want to think about it that way. So firstly, I look for associated symptoms such as incontinence, nocturia, hesitancy, terminal dribbling, double voiding. And urological causes, you also look for associated haematuria as well. So you can think about BPH, stones, UTIs, malignancies. And for neurological wise, it could be actually a whole host of problems. So problems from the cauda equina to the spinal cord, to pathologies that cause autonomic dysfunction such as diabetes mellitus, Parkinson's as well. Many of these neurological disorders can cause some form of urinary problems, either through affecting the autonomic system or directly affecting the spinal cord or the cauda equina. Drug history is important as well. So next would be the polyuria group, and this is defined by a urine output of greater than 3 liters per day. So I think for this, something in history may not be the easiest to suss it out, but if patients give you a history that, okay, I'm passing not just frequently, but large volumes each time around, then polyuria should be something that you may want to assess for. So the way I think about it is to try to get the easy to ascertain causes out of the way. So first would be number one, is there anything that's causing me to drink a lot? So conditions such as things that predispose to my mouth being dry. So the patient says that, I'm passing a lot of urine, but I also noticed that, I'm having this very pronounced dry mouth, and I'm drinking a lot of water because of that. You may want to think of a sort of a secondary polydipsia of sorts, where there is an impetus or trigger for the patient to be drinking a lot. So Sjogren's, for example, anticholinergic medications may be causes for that. Or there's a psychiatric overlay to things, psychogenic polydipsia should be considered. The next group would be that of actually diuretics. So taking a drug history is important. The patient has just been newly initiated on certain diuretics and is passing lots of urine. Then, that could be the intended purpose of it, and the polyuria could just be due to the diuresis. And thirdly would be that of osmotic diuresis, right? So in patients, commonly would be that of diabetes, poorly controlled DM. If they have poorly controlled DM and then they are passing out urine frequently in large volumes, that is something that can be explained away due to the osmotic effect of glucose. And then that's where we subsequently come to the DI group of conditions. So in nephrogenic DI, this is a problem with being able to respond to ADH, and in cranial DI, this is a problem with inadequate production of ADH. So nephrogenic DI, common causes would be that of hypercalcemia that can be seen in Mann syndrome, sarcoid malignancy, and lithium administration. Cranial DI can be associated with any form of pathologies that happen in the intracranial system, such as trauma, surgery, so on and so forth. So this is just a very conceptual summary of how we go about a DI workup. I think the first is to ascertain whether or not there are medications on board, like diuretics. And then next is whether or not the urine osm is high. So if it is high, more than 600, then this is in keeping with osmotic diuresis, such as due to high sugar levels. And in such instances, if the urine osm is already high, then we don't typically go ahead with further evaluation with a water deprivation test or hypertonic saline test. In patients where there isn't a suggestion of osmotic diuresis and the urine osm is low. So typically we take the cutoff of less than 300, and sometimes between 300 and 600 urine osm per kg, it's kind of a gray zone. In those instances, then there might be a role for water deprivation test, and the key really is to try to differentiate whether this is DI or some form of polydipsia. If in the midst of a water deprivation, you would expect as a patient is no longer allowed access to water, the urine would become concentrated if it is due to too much drinking of water and polydipsia. But in DI, because it is the urine, or rather the process of either an ADH non-response or non-secretion, because this happens though, you would expect the urine to remain dilute in DI that is due to either a cranial or a nephrogenic source. Then subsequently will be the DDAVP challenge that happens after the water deprivation. And in nephrogenic, there is no response to the DDAVP because it is a problem with sensing and responding to ADH. Well, whereas in cranial DI, where it's a problem of production of ADH, you would expect the urine to become concentrated with the administration of DDAVP. And this process can help you differentiate between the two causes. Yep, so I hope you found this helpful. Thank you.